Professor Sievert, maybe you can stay there because you also have to moderate. Professor Pansadoro, you can go there. And we have Marek Zawadzki. Perfect. And Professor Tailly. Where is Thomas? Okay, you will arrive in any case. So Davide, please present the cases.
Okay, so can I start with my presentation? The clinical cases. Okay, so in R1 we are seeing a miniaturized, unblocked, no-touch, low-power HoLEP done by Dr. Scofone on a 77-year-old patient. Patient is under antiplatelet therapy for primary prevention. The patient has got a prostate diameter of 56 millimeters and had a post-void residual of 105 milliliter. He had in September an acute urinary retention, and after that we failed to remove the catheter, so he's he has got an indwelling catheter. He performed a prostate MRI showing a prostate volume of 82 milliliters, and he's got an ASA score of 2 and a negative culture after a course of antibiotic. We will see a particular instrumentation today. So we're going to see the RZ miniaturized set for enucleation of the prostate, which is a 22 French urethra sheet with a dedicated working element for the laser and also a dedicated resectoscope. A cyberholmium from Quanta system will be used, and a dedicated RZ morsoscope is going to be used, and it's compatible with the STARS drill cut morsolator.
Okay, open the basket.
So we'll come back to you in a minute, and we'll switch over to Professor Scofone for now to see him start with the HoLEP procedure. We'll come back to you in a few minutes' time.
For sure.
So, hello.
Hello,
Good morning to everybody.
We see you.
So we are starting a miniaturized, low power, no touch enucleation of the prostate with the all-new laser. And today I will use this new instrument. It's an instrument, a resectoscope from RZ Medicine with the outer sheet 22 Charrier. The inner sheet is 19. And we have also this working element for the laser. I want to underline that is as the standard instrument from Karl Storz that I use. The tip is tapered. This is very important because I switch the light. You can see better the tip. It's very important to have this tapered tip because it's mandatory to have our laser fiber stopped and not moving during the surgery. So I am with Felipe Figueiredo in my OR. Unfortunately, he can't operate because he's extra European colleague, so he can't operate. But I wanted to have him here because the idea of this instrument was his idea. So I'm really proud because Felipe is one friend since a lot of years. And now I want to only to show you the setting of the laser. And after I start the procedure, and I can leave the word also to Felipe to speak about some concept and the advantage of this smaller instrument. Our setting for the laser is one of the concepts of our enucleation is the low power. So we are using for this laser 2 watts and 20 hertz with the virtual basket mode of this 150 Cybero Quanta all-new laser. On the other side, on the right, we have 2 Joule 20 hertz and long pulse length that is set in the preset of Quanta as a vapor tunnel effect. So this is what we are normally doing, and as you can see here, I am going inside into the urethra, and this caliber can allow us to go really in a right way inside. So you can see here the verumontanum, the shape of the prostate. There is one small close, the bladder neck, and the 2 orifices. One is here, and the other one is here. I think that it's better that I started to do the enucleation. I want to show you the first really important step, and when I started to work, Felipe is explaining exactly the concept of this early detachment of the sphincteric mucosa, because there is a sort of philosophy based on the anatomy of the sphincter. So as you can see, this is our mode. Can you put in ready the set ready, please? Okay, so we start with this reverse U around the verumontanum. I think that there is a right distance, and I think this distance of the tip of the fiber is the right distance that I can see and can move not the working element but the instrument. So I started to do a reverse U incision around the verumontanum, and after I am doing another reverse U incision till 12 o'clock. And now I leave the word to Felipe, and I can start to speak about the rationale of this.
Yeah. So Cesare is starting in the easiest way to find the correct plane. If we analyze the anatomy, the endoscopic anatomy of the prostate, the verumontanum is the most important landmark. And on each side of the veru, you have only the mucosa of the prostatic urethra, and then you have the surgical plane. So if you do a blunt movement, you can find the plane, but it will bleed from the mucosa and from the vessels. But if you start with the laser, you can incise the blood vessels and coagulate at the same time. And then once you get in the plane, you start with these blunt movements, and then you will fall directly in the correct plane.
I think that this is immediately the ampulla, and the plane is here. You see, when we touch, when we incise here, we are not in the right plane, and the right plane is here. Okay, this is something happened, and I am really happy to show you. This is the ampulla, and the right plane is here, and I have to take care, because the plane is not this plane, but is this plane.
Cesare, can you explain how the tip of the endoscope looks, and if it helps you to find the correct plane?
We cannot hear you, Marek.
Yeah. I want to hear how the tip of the endoscope looks, and if it's blind ended obliquely, or it's a pin, how it's looking like.
The tip of the receptoscope, you mean?
Yeah, the shape of the tip of the...
It's the standard tip with the ceramic tip, and usually it's not 90 degrees, like oblique, maybe 30 degrees. It is the standard sheet for TURP.
Can you increase the height of my bags, please?
Could you tell us about the settings that you're using for resection and coagulation?
So the settings, he's using 2 joules, which allows you to have more mechanical dissection. So one of the unique advantages of the Holmium laser for nucleation is to have this photomechanical effect that you get with the bubble. The short pulse duration and the high peak power allow you to have infiltration of the plane. So you create tension with the tip of the sheath, and the bubble completes the nucleation. And so the more energy you use, the more mechanical effect. It's possible to use different settings. Personally, with the 18 French resectoscope, I think that 2 joules is too much energy. So I converted my technique to a shorter working distance, and you can use 1.2 joules and higher frequencies, and you keep the low power. But Cesare likes 2 joules, and he used 20 watts. So there is some publications with even 30 watts HOLEP from Japan, but it compromises a little bit the efficiency with 30 watts. I have tried it in a few cases, but I think from 40 to 50 and to 60, you can have good enucleation efficiency with less energy delivered to the capsule. So this may decrease the rate of post-op dysuria. I don't know if Cesare feels like that, the dysuria using low power.
I think that before following in the discussion about this issue that is very important, I want to show you how the plan is very, very thin. This is the wrong plan because it's the capsular perforation to the ampulla here, and the right plan is here. So if you can see here is 1-2 millimeter of tissue separating, especially at 6 o'clock. So the right plan is here. I recover the right plan on the left side, and I coming back to the other side in order to have the right plan in the other side, okay?
Cesare,
So-
what's your plan to preserve the mucosa? What's the strategy to decrease the stress urinary incontinence?
Yes, the most important issue is to save some part of the mucosa, half centimeter of the mucosa into the apex in order to stay a little bit far from the sphincteric mucosa. Is the way to have less thermal damage for the sphincter, and also less traction on the mucosa. But the most important thing is to detach earlier this sphincteric mucosa, because this is the way to... just 1 second, I have to...
And when will you
complete
release
it,
the rest
the
of the apical
detachment is-
mucosa?
Sorry?
At what point will you release the rest of the apical mucosa?
I release circularly this is the other ampulla with some... I have to detach at 6 o'clock. Sorry, just 1 second. I have to connect the right side with the left side, because I have this bridge.
Cesare?
Yes?
Yeah, can you comment on the advantages of doing one block? Which is the advantage?
There are a lot of advantages. In my opinion, one of the advantages is that you don't have to find your right plan in 3 different points, 5, 7, or 12 o'clock, but you find the right plan just around the veromontanum. And the second advantage is the speed of the surgery. You save a lot of time. And now I want to show you, okay? I'm doing the detachment of all the inferior part of the prostate, and I am coming back to the bladder neck here. You see, this is the flap of the mucosa. This is the so-called white line that normally we don't cut here, but we cut here. we have the adenoma here, and we save this part of sphincteric mucosa because here is starting the sphincter, okay? So we stay here and following the plan that we already detached a little bit from 6 to 4 o'clock in the left hand, and coming back, I need to cut this mucosa till 12 o'clock, means till here, and the same on the other side, okay? I cut this mucosa in one side, and I would like to do this the same on the other side. So I have to cut here till 12 o'clock.
Beautiful apical release, Cesare.
Yeah, if now
nice.
we have to go here.
I see
and,
I see that Professor Straub is in the kidney, eager to get started on treating the stone.
You can follow this detachment directly on the screen, and after we can discuss. No problem.
Perfect. Thank you. We'll be back with you in a few minutes.
Around the prostate now. So here you can see. Yes.
You're back.
Can you hear me?
Yeah, yes, we hear you. We hear you.
Okay. This is the prostate. So we start to show you 9 o'clock, 10 o'clock. This is the line that I have to incise here. And what is very important, and when you arrive into the just close to the bladder neck, the diameter of your prostate is decreasing. So you don't have to go straight, but you have to do a curve. And when you are at 12 o'clock, you have to do a curve towards the downward parts of the bladder neck. And here we are around the prostate. We completely detach all the prostate, you see. Look, I am going around. So now I want to arrive progressively on the bladder neck. And another important concept of our surgery is also the no-touch concept. You see, we are using, here there is a vessel. I have to coagulate because the vision here at 10 o'clock is not so fine. I have to detach a little bit more here to arrive on this vessel.
So the point of entry inside the bladder is at 12 o'clock for you, Cesare, or it's on sides?
Normally is 12 o'clock. I prefer to do this at 12 o'clock. When I see the circular fibers of the bladder neck, I go inside at 12 o'clock. And this is for me a very good moment in which look at the circular fiber of the bladder neck here. You see the anatomy, the detail of the anatomy is very important. I am very happy when I arriving, and normally I am doing a sort of smiling face when I arrive here because I am really happy because it is a very important reference point for the nucleation of the bladder neck. So, you see, you can coagulate every single vessel, and especially in the bladder neck, it's important to cut not here in the border, but here, because there are some vessels, and you need to have some part of the artery in front of you. If you cut here, the artery is going inside into the bladder, and this could be more difficult to detach. Look, this is the bladder neck, and normally I'm doing this like a face every time because I'm very happy for this. And when you have this reference point, you have to follow the bladder neck and detaching the mucosa of the bladder neck in this way, because it's very important to save the bladder neck. And if you see some artery, you have to coagulate when you are doing this. Okay?
At what time of the operation you are checking the UOs?
You mean the urethral orifice?
Yes.
At the end, only at the end. If I can also check the urethral orifice when I started, like in this case, because they were really distant from the bladder neck. So was easy. But if I have a big middle lobe, it's impossible to see the orifices before, because you have to push, and the pushing could be that you can have bleeding, and bleeding is not good, especially when you start. If you have bleeding when you start, it's not good. You see, I changed my foot pedal to the other setting, so I changed the bubble, the shape of the bubble of my onion laser, from the two bubble of the virtual buster to the single long bubble, and not so wide bubble of the long pulse length, and in this way is easier to coagulate. And also for coagulating, I think that all the enucleators agree with this. You don't have to stay in front of the artery, but you have to stay and starting beside the artery in order to make collapse the artery. Because if you stay in front, the risk is that you can push the artery inside without coagulating it, and this could be for sure a risk of bleeding inside into the capsule without seeing the tip of the artery. So very difficult. So I'm going the other side of the bladder neck now. I am here, okay? I want to check, this is the artery that I tried to find before. And also it's very important for coagulating with this laser not having blood into the field. Because as you know perfectly, this laser is well absorbed only in the water, not in the blood. So it's not efficient if you have this red field in front of you.
Cesare,
Yes.
the size of the adenoma plays a role in your indication. In other words, do you have a limit of where you do the unblock removal?
This is the question. This is a very good question, and this is the question that normally asks me everywhere from everybody. And now, after 10 years, I can tell you we don't have any limitation on the size of the prostate. But as normally I'm saying, and I had a very good debate in Barcelona about this in the masterclass of the laser. I think that you have to know that enucleation of prostate more than 120, 150 grams is another championship. Is not a normal enucleation of the prostate. So I think that for the learning curve to reach a good skill in the enucleation of prostate till 100 grams is not easy, but after 30 to 50, depending on the kind of learning curve that you are planned for yourself, and also the teacher that you have, the mentor that you have. For the big prostate, I think that you need minimum 200 enucleation, because it's another championship, because you can have sometimes really big problem of bleeding or plan. Is not easy. So this is important.
For me, for over 150 grams, I think there are some specific challenges in the big prostates for the block. And one of them is your ability to push the adenoma completely through the bladder neck. Because the bigger the prostate is, the proportion between the adenoma and the opening of the bladder neck is increasingly difficult. So for me, I do at the end, after the enucleation, one bladder neck incision at the adenoma at 5 or 7 o'clock. So the adenoma, instead of a donut, it's like a horseshoe. And then you can push one lobe through the bladder neck, and then you push the second lobe. And so it's easier to push one lobe at a time through the bladder neck before morcellation. Sure. But if you cut at the end, the adenoma is already devascularized, so it's a very easy incision. You don't have any bleeding, and you have more mobility sometimes to finish this posterior enucleation of the bladder neck.
Thank you, Felipe and Cesare.
I think that just 1 second,
Sure.
Thomas, because I am finishing my enucleation. So this is the last part of my enucleation, and you see we started at 30, it's 25 minutes that when We are started and we finish now, and we are pushing the adenoma into the bladder. Okay.
That's
You're
a beautiful
very fast.
enucleation. Beautiful.
So we have to switch back because otherwise the stone is gone too. So
Okay.
we'll see you in a few minutes.
Okay.
Cesare,
Hello?
we are with you.
So thank you for giving the line. We finished the nucleation, push the piece into the bladder, control the urethral orifices, control the sphincter. I hope that you could see the sphincter before. If not, at the end of the morcellation, I can show you. And now we are using this Morse scope. This is a 15 French cystoscope with it's like a nephroscope, and it fits exactly in the sheet. And Felipe want.
Yeah, actually, this is a 22 French Morse scope, so it's not for PCNL, only for morcellation, because it doesn't have an PCNL outer sheet. This Morse scope fits directly in the same outer sheet of the resectoscope. So we finish the enucleation, we change the camera, remove the inner sheet, and put the Morse scope directly. So the challenge was to be able to pass the morcellator blades, that is usually 4.8 millimeters. So we needed a 5 millimeter channel. But 22 French sheet is 7.1 millimeter, the outer diameter. So we had to reduce the size of the optical system, the lights, to allow good irrigation. So we decided to put a fiber optic nephroscope. You see, there are some small dots. So the quality of the vision is not the same as the rod lens, but I think it's a good trade-off. Otherwise, we would have to change for a larger sheet for morcellation.
Another important word is also for the morcellator. We are using the morcellator from Karl Storz, and we are using now 2,200 rounds per minute. And as you can see, it's really efficient. The characteristic of the morcellator is to maintain the piece on the tip, and when the piece is getting smaller, sometimes it's very difficult to maintain it. And you can decrease. Can you decrease the speed now till 1,600? And also, other rules, important rule for the morcellation is to have always the backs very high, the bladder completely full of water, and stay stopped in the middle, because when you run, just running towards to try to find your piece, in this case you risk to have the bladder injuries.
So some colleagues are referring that they keep the adenoma still attached to the bladder neck and then do the morcellation. What do you think about that aspect, that it does not run around?
Never I detach completely the adenoma in order to have more mobility of the adenoma. And if I have a situation like this one in which I can't see very well, I can put my resectoscope and I can cut. And it's very important to see the bladder wall. You see here, there is the bladder neck, so I am a little bit inside. I can stay here, but you have to take care that the bags are always full, not empty.
So usually,
and following every step of your morcellation. This is very important.
Hi, Cesare. Very well done. It's Mario. Hi, Felipe. I saw that you practice some fulguration. This is a routine. This is the first question. And the second one, if this set has also an adapted 22 French resectoscope handle.
Yes, I am doing always the check with the resectoscope for two reasons. Because the other set that I'm using for the working element of my laser is a working element with the tip really outside of the sheet. So I am a little bit worried about the risk of damage the urethra when I check the sphincter or the urethral orifices. Sometimes, sometimes I have clothes into the prostatic fossa, and with the bipolar I can push away my clothes and checking if I have some pieces of adenoma that remains in the prostatic fossa, and also to check the sphincter is better to see with the bipolar. As normal, this is another question that everybody asked me since 10 years, but I normally make this example, for example, on the enuclear resection of the bladder, of the kidney tumor. So in the kidney tumor, I am using normally 3 different energy sources, and I think that if you have these energy sources in your table, you don't need to change instrument, and you use like this one. You have the bipolar. I can check everything. Okay. If you have these clothes, I can push the clothes without any problem, and seeing what is the situation of bleeding just around the verumontanum here.
You prefer to use the loop or to rollerball?
No, I prefer to use the loop. Normally I use the loop, is my habit. And we check again the urethral orifices. One is here and the other one is here. We have this piece in the bladder. A bridge of the mucosa. I can cut if I want this bridge, like in TRP, okay? This is the bridge of the mucosa that I save, but is completely detached. And now I have, yes.
We see that Dr. Straub has finished his procedure. Would it be okay if we switch over just to see his exit strategy, and we'll come back to you after that?
Absolutely, absolutely, yes. In 5 minutes, we can put a catheter and we can see.
Perfect.
I already checked the fossa without irrigation. So this is the fossa without any irrigation. And I checked that we don't have any other pieces, the urethral orifice again. And now I think that we can put a catheter, okay? So normally the exit strategy is to insert a 20 Charrier catheter with normally 10 cc more than supposed volume of the prostate. So in this case, I put into the balloon 60 cc, and I maintain the catheter into the bladder with a very, very gentle traction, only to maintain closed the prostatic fossa in order to avoid some venous bleeding. And normally I make an irrigation till tomorrow morning, stop the irrigation and remove the catheter in the second postoperative day. This is my postoperative routine to maintain.
Do you have any strategy for the removal of the catheter? Any wash of the fossa or wash of the bladder?
Normally we wash the fossa with some saline in order to remove some clothes that could stay into the fossa. So I have to make completely empty the bladder, because I have to check if there is no bleeding. You need to remove all the water, all the saline that you have inside, and after this you have to wash, and your irrigation has to have the same color from the entrance, so it has to be transparent. So now we finish, and Gabriele now is giving me a syringe, and it's very important that I put the saline inside, and the color of the outside irrigation is the same. Where are you? Is the same of the entrance. So it means that it's not bleeding anymore. Okay. and I use to put a gauze around the catheter like this, only to maintain this small traction, this nice traction on the bladder neck, and as you can see, the irrigation is completely transparent. I think that I want to underline the very important issue of miniaturization of the instrument at the end, because I think that in 15-20% of the cases with our big instrument is very difficult to entry and to assess the urethra. Yes, you can use the Otis urethrotom, you can use also the way to dilate the urethra or to put a catheter, but due to the fact that the laser allows us to use a very, very small fiber, no reason to have a big instrument for enucleation. And I think that this is for sure the way for the future. And at the end, I want to thank all the OR team, also the two ORs, because if we can realize this event, it's really important to have our team, the scrub nurses, the anesthetists, and all the nurses in the OR, and they are very important for us. And I want to thank in front of you all my team, and also Dario, and also my coworker, because it's very important to have a good team to realize an event like we are realizing. So thank you very much to everybody for this.
Thank you very much.
So thank you guys for staying until now. Now it's lunchtime. You have 1 hour.
So we move on. The next presentation is a technical aspect on immune laser enucleation by Felipe Figueiredo. He wanted absolutely this presentation in the TNT because he wants to share with you all his experience in this. And as moderator is me, and also Dimitri Enikev is via web. Okay.
So this is the last lecture of the meeting, and I would like to congratulate Cesare and Cecilia for another amazing TNT. I believe this meeting is the best endourology meeting in the world, especially for enucleation of the prostate. And we always meet a lot of friends that I have made here in the last 6 years, and it's really glad to be back after the pandemic. So we are going to talk about technical aspects of HoLEP, and I can change the slides here. Yes. So my disclosure, I have helped in the development of the smaller sheets for this company, RZ, and also for the extra long resectoscope. And I run HoLEP courses for Quanta, the Casa Quanta training program in my hospital since the beginning of the year. So the perfect endoscopic enucleation, ideally you should leave no residual adenoma, you have no perforation, no bleeding, no urethral trauma, and consequently some stricture formation, and no transient incontinence. And we usually divide anatomic enucleation and non-anatomic enucleation if you are following the perfect anatomical plane, as Tev has shown brilliantly. So we have TULIP or TUVEP, and the same with other energy sources. And the problems with non-anatomic enucleation is that if you penetrate the peripheral zone, usually you have more bleeders. So usually you have sinus veins, and sometimes difficult to coagulate large veins with the laser. If you have a free perforation, you may have fluid absorption, and eventually during the learning curves, people have to open the patient for large fluid collection in the peritoneum. And if you have residual BPH tissue, it may regrowth in the long term, and also you have some necrotic tissue during the healing process. And in my experience, this increases the dysuria rates if you don't do the anatomical enucleation. So there are 3 different ways to perform enucleation or HoLEP. You can do a blunt enucleation, an energy-based nucleation, cutting the tissue. That's how you do with vapoenucleation, and the no-touch technique. And I'm going to show the differences. So the blunt enucleation, we use the tip of the resectoscope as the index finger for open prostatectomy. So we do a lot of blunt movements. It's how you basically do for MiLep. Most of the surgery is blunt enucleation. But you can also do for whole lip, for two-lip, as Thomas Herman have described. And this is the best way to find the plane lateral to the vero. If you go and do the small mucosal incision, if you push the tip of the resectoscope laterally, you usually get in the perfect plane. This is the easiest spot. But the problem is that you disrupt the vessels at the level of the capsule without coagulation. If you don't do coagulation, when you come back, you have a lot of bleeders. So you have to go again the same place to do the coagulation, and you lose time. So sometimes it's faster to do this blunt movement, but at the end of the surgery, you spend more time doing hemostasis. So bleeding is the first problem with this technique. It's also a problem in smaller prostates. If you try to do this in a less than 50-gram prostate, sometimes you don't have the perfect pseudocapsule around the adenoma, and you enter the peripheral zone, or even to have a perforation. So it's a more risk of perforation, and sometimes you use a lot of force against the membranous urethra as a lever, and this is another way to damage the sphincter. So you have to take care with your hand movements and try not to be very aggressive, because this is one of the mechanisms of sphincteric damage and probably related to the rates of transient incontinence. The second way is to touch the tissue with the fiber tip and have this cutting effect. You can do this. This is how we see sometimes with some surgeons. They are very fast, they know what they are doing, but it's easier to lose the plane. So most of the times you don't do a perfect anatomical enucleation. You go a little bit inside of the adenoma and you leave some adenoma behind, or you have some capsular penetration and you resect the peripheral zone. So this is fast in experienced hand, but it's not anatomical, and this is not easy for people that are starting. And if we analyze the homeolaser with the high peak power, is a pulsed laser, is absorbed by water, and we have two main effects. We have the thermal effect that works very close to the tip of the fiber, and you have the spreading scissor effect, the mechanical, photomechanical effect of the bubble that helps to open the plane and to infiltrate the plane that shows the way during the enucleation. So the idea of the spreading scissor is that when you create tension with the tip and you fire the laser, the bubbles opens the plane like you do with the scissor in open surgery. And in this video, we can see clearly the effect of the bubble helping to open the plane. But if we analyze, we don't see any coagulation here. So if you work from distance, you do like the blunt enucleation. You disrupt the vessels and you have more bleeders. And this usually helps with more energy, and especially with short pulse. So if we analyze the vectors of the enucleation, we have a macromechanical dissection when you push the adenoma against the plane, and you push, and this is the base of the blunt enucleation. But if you go just creating tension and you fire the laser, the bubble completes the enucleation, and if you can have a good control of the distance, you have the first pass hemostasis. If we think about the different energy settings that you can use, the most popular is the 2 joule, and this creates a very short thermal zone and a big bubble of almost 30 millimeters. Of course, the mechanical effect is stronger, closer to the fiber tip. But if you use 1.2, you have almost the same size of the bubble, but a shorter thermal zone, so you have a closer working distance. And this is especially important with the smaller sheets. The continuous wave lasers, they don't have the bubble, so you lose this physical aspect that can help in your enucleation. This is the most important slide for me to understand how to use the Homium laser. This is how much of the energy is absorbed by the tissue according to the distance between the fiber tip and the tissue. If we analyze Homium laser, is a short distance laser, so if you are in contact, you vaporize the intracellular water and you cut the tissue. So it's the energy-based enucleation. If you are above 3 millimeters, no thermal effect, only mechanical effect. But if you work between 1 and 2 millimeters, you have only the coagulation effect, and if you create tension, you can do the first pass hemostasis. So you have the mechanical effect of the bubble and the coagulation at the same time. This is the basis of the no-touch technique that Cesare Cecilia described brilliantly in 2015, and I think this is my favorite way to do HoLEP, because you don't have to come back for bleeders after the enucleation. You have less risk of bleeding during morcellation, and this is something we have to master, this distance control. I think this is the most difficult part for the beginners. So if you touch the tissue, you have the vaporization effect. If you work from 2 millimeters, you coagulate the surface, and this is what we try to do. If you see here, I'm creating tension with the tip of the sheath, and the bubble is finishing to disrupt the adhesions, and we are coagulating everything. So we should try to paint everything of white during the surgery. And it's easier to keep the plane. You can do the anatomical enucleation, no residual adenoma behind, or very few, and very few capsular penetration. It's very rare to do a perforation, but you move a little bit slowly. So this is the concept of the first pass hemostasis, but this is only possible with the pulsed lasers. With continuous lasers, you don't have this peak power and the bubble. And using smaller scopes, there is one difference. If we think about the distance between the tip of the fiber and the enucleation plane with the 26 French sheath, you need 2 joules to reach it, but you also can advance the fiber. But when you decrease to 18.5 French, you are working closer to the enucleation plane. So for me, if I use 2 joules, I cut the tissue. So I had to decrease the energy to 1.2 when I use the 18.5 French sheath. With the 22 French, you can use both, but currently I use 1.2 in most of my enucleations. And what about pulse modulation? Actually, we always talk about the 2 pulses, the double pulses. We have the Moses technology from Lumenis and the virtual basket from Quanta. And it's easier to keep the coagulation distance with this laser. We have this brilliant talk, 2 talks back, showing that you can fragment the stones in a distant mode using the double bubble, but it's the same for coagulation, so it's faster with double bubble. Sorry. So the idea is to have a short pulse to open the path, and the second pulse is a long pulse that goes through the first bubble, and so you reach the tissue more efficiently. And the long pulse has actually a better coagulation profile, and this is my favorite modulation for hemostasis. Not the virtual basket, but the longest pulse duration that you can achieve modulating in your lasers. Most lasers now you can choose the short pulse and long pulse, but this long bubble, the vapor tunnel, has better coagulation. This is my favorite setting for the final hemostasis, for hemostasis of the mucosa, and this is the 7th duration. With the Quanta laser, you can choose 7 different pulse durations. And the longest one is the vapor tunnel. So I put this vapor tunnel in one of the pedals for hemostasis. With the double bubble, you have a longer reach. And the bubble blast is more for PCNL. You have 2 short pulses, so you have more mechanical effect. But the biggest problems are the transient incontinence and the strictures. Because if the patient has this complication, they feel worse than pre-op. And we are treating a benign disease. So this is really related to the surgical technique and to understand the anatomy of the sphincter. And this is important during the learning curve. And this concept is extremely important, the concept of the musculus sphincter urethrae. is a different muscle unit independent from the pelvic floor muscle, and it's completely separated by connective tissue. We have two different layers, an inner layer of smooth muscle fibers that's called the lisosphincter, and an outer layer of striated muscle fibers, the rhabdosphincter. So in this drawing, we can see that the rhabdosphincter is very strong, but the lisosphincter is closely related to the mucosa. We have an outer circular layer of smooth muscle and an inner longitudinal layer that was Thomas Herman likes to preserve anteriorly in the technique he have shown us in the first day. And in this British paper, they show that it's very closely related to the mucosa, the lisosphincter. It takes around 1 or 2 millimeters. So we have to consider that the mucosa is the lisosphincter. And it's more proximal anteriorly. So if you analyze this picture, you see the rhabdosphincter growing outside of the prostate, but the lisosphincter grows up to the level of the vero. So you have to preserve an anterior mucosa if you want to have immediate continence after enucleation. So you can cut the sphincter if you cut in the wrong place. And this is common at 12 o'clock because of the more proximal part of the sphincter. If you do a 2 or 3 lobe technique, usually you start the 12 o'clock incision at the bladder neck and you go back and you are not looking at the vero. And if you go too distally, you may damage this anterior part of the lisosphincter. So this is permanent incontinence. How can you prevent this? You have to create an anterior reference point. So you look at the vero, you point up, and then you create a mark, a deep mark with the laser, and then you connect this mark to the lateral dissections. And this is an example of another way to damage the sphincter. If you do the blunt lifting of the apex without incising the mucosa, you will tear the mucosa on both sides of the vero, and this will damage the circular layer of the smooth muscle. And you create a lot of traction in the sphincter. So this is an important concept. If you damage the continuity of the mucosa like this, you are tearing the lisosphincter. So you have traction and tearing as two important mechanisms for incontinence. So the other way is to use the endoscopic landmarks to incise the mucosa. So we have the vero, we have the contour of the convexity of the lateral lobe, and you have the wrinkle that usually you can use to incise, like Tev showed today. So Dr. Gomez-Sancha have described the MiLep technique using the white line with the green light laser and releasing the sphincter before the enucleation. And he used the same technique for HoLEP, describing a lower rate of immediate incontinence. But sometimes you cannot see the wrinkle. So sometimes it's not easy to know where to cut. And we described another technique for early apical release in 2020 with Cesare and Cecilia, is the progressive cut, where you do the dissection of the posterior plane, and when you see the contour of the capsule, you do the vertical incision, and then you enucleate a little bit more until you have the mucosa under tension. So you have to intercalate between the incisions and the dissection of the plane. And that way you can avoid tearing the mucosa, but you know where to cut because you are looking at the capsule. So this is the aspect. You do 1, 2 ascending incision and a third descending incision from the anterior reference point to the previous incisions. And this should be the final aspect of the sphincter. You need a longer anterior flap of mucosa and no tearing on each side of the vero. Once you release completely, you are done. Thank you very much.
Thank you very much. I would like to have a comment. Leave me, please, Dimitri Enikev on the screen. Leave me Dimitri Enikev on the screen, please, because I would like to have a comment from Dimitri about the early detachment of the sphincter, and also about the dissection, the enucleation, blunt or micromechanical dissection or macromechanical dissection. Which laser are you preferred?
Well, Cesare, it's a good question. I'm just sure that lasers are merely tools in the hands of a surgeon, like paintbrushes are tools for an artist. And of course, the main aspect is the result. And of course, but if we talk about techniques, so in my personal opinion, so I combine mechanical effect with lasers. So for me, it's not so important which energy source to use. I have my personal opinion on that. That in some aspects, it's easier to learn enucleation with thulium due to its photothermal effect, because you can easily cut the tissue. But it's up for discussion. As for early apical reliefs, we know that there are also several opinions on that. We know there are several publications on that. That on the one hand, it decreases post-operative urinary incontinence. On the other hand, there are other trials that didn't find any changes between the technique with and without early apical reliefs. And of course, we need more randomized clinical trials. On this topic to discuss it maybe in future. But I would like to really, first of all, thank you for a very interesting presentation. And I have one question I would like to ask you. So during my enucleation experience, routinely I use 26 French resectoscope but at hand I always have my personal 24 French resectoscope if there is rigid urethra. Visibility may be the same, so it's also very interesting to use 22. But the main question is for 18.5 endoscope. So to perform, maybe you can perform enucleation. I'm sure you can. But the next step, morcellation. Currently, there is no blades for morcellation which can be available for 18.5 endoscope. So you have, in my opinion, you have to change the endoscope for the morcellation, and you go with the endoscope for the urethra again, and maybe it's not so the best option at this moment. Maybe you heard any ideas of developing a morcellator that can be that you can use with 18.5 endoscope. Felipe?
Yes, I think. Hello. I think this is a great question. If you have to use the 22 French for morcellation, why do you do the enucleation with the 18? The problem is that you spend most of the time with the 18 French, and all your lateral movements and turn around the adenoma, so all the trauma usually occurs during the enucleation phase. The morcellation, usually you only introduct and you keep stopped in the middle of the bladder. So it's not only the size, but the movements that you do with the sheath. So if you see this final aspect of the mucosa, this is 18 French enucleation. With the 22, you have this whitish appearance of friction in the superficial layer. The clinical significance of this, maybe we have to show later, but I see less and less dysuria in the first week after surgery, because I have less trauma using the smaller sheets. And some cases, you cannot pass the 22 French at the beginning of the surgery. And with the 18, you do all the work, and this dilates the urethra in the 30 minutes that you are using. And then at the end, you can pass the 22.
Okay, thank you very much. Thank you, Dimitri, for your being here with us. Good luck. Hoping to see you next year.